functional assessment with patient after the reconstruction Achilles tendon. First, why the doctor from our team make the reconstruction and why hamstring graft. Patient, we take to the reconstruction patient with chronic incomplete tendon injury or re-rupture where conventionally suturing is not possible when the tendon is not is really worse. The operators decide to take the graft as in the ACL reconstruction. They take the hamstring, the gracilis, and the semitendinosus tendon. And why they take this tendon to reconstruction to not to additionally traumatize the area of the lower leg and foot. We can see in different way on this operation to take, for example, the hallucis flexor hallucis longus, for example. But for our opinion, this is a really important muscle. So we don't want to take this muscle and not traumatize this area around the Achilles and around the foot. This is how it looks. This is some paint. Here we saw the endobutton in the hell bone. And it looks like the same like in the tibia bone with Achilles ACL reconstruction, and then the tendon go here to the rest of the held Achilles tendon. Doctor, you use the minimal cut the skin. Because this is give us better work with a scarf, for example. If someone want, if somebody want read about this kind of reconstruction, this is some article from our team where the doctor show step by step how he make this. Every patient after direct reconstruction, go with the rehabilitation around this protocol. We cut this protocol for the stage, 6 stage, and it's something around 12-15 months after the operation. But for me, like a physiotherapist, the most important after this reconstruction is this to patient after first and second day after the surgery, they walk kindly normally because they had a walker orthesis. First 2 weeks they go with the crunch, but after this he walk kindly normally. And to the 4 weeks, most important for me is we don't work with range of motion, especially with dorsiflexion, because of course we try safety as hard as possible the Achilles tendon. But after 4 weeks, we take up the orthesis and we start work with range of motion, and especially we start with work with strength of the muscle from the calf. This protocol is also in the article. We share this in some Polish journal, Irons. So if someone want read some details, I show you the article. Okay, when and what did we during the biomechanical functional assessment? First assessment we did 12 months after the surgery, and the second is 24 months after the surgery. We have 37 patients on 12 months and 30 patients 24 months after the surgery. And the assessment included first subjective evaluation, the pain and the satisfaction level, and included the visual analog scale, VES scale, of course, The Achilles tendon total rupture score ATRS, the quality of life questionnaire, and the functional assessment, evaluations, the weight bearing lunge test. This is test for the range of motion, the head rise test for the strength, for the calf muscle, a single leg hop test, calf circumference measurements, and the last part of the assessment is isometric and isotonic evaluation. We did this on the Biodex with 30, 60, and 90 degrees per second. And here we look on the concentric and the eccentric strength for the gracilis and soleus, gastrocnemius and soleus muscle. This is some of the tests, the functional test, weight bearing on the left side. We like this check the range of motion, then the strength of the on this box. Hop test, where we look on the of course the centimeters, but of course on the functional and on the how the patient jump. And the Biodex we did in this position, the front leg position with straight knee. In the full statistics, we have completed the result of patient. Here, okay, of patient with torn and rare ruptured tendons, 12 and 24 months after the reconstruction, and as well as group 12 to 24 months after the surgery. So we cut the group for the two groups with the total and not total injured, and on the 12 and the 24 months. And why I can't. Okay, here, sorry. Okay, and first I show you some tables, but I will not show you details, because if you want, it's also in the article. So first, we clinical evaluation of calf circumference. The injured leg showed slightly decreased maximum calf circumference that the opposite leg in almost all cases, but the difference was not significant. The subjective outcomes of the surgical procedure, for me, the most important is this: that when we look on the 12 and 24 months after the surgery, 24 months after the surgery have better results, and the better results is improved significantly months after the 24 months after the surgery. The functional outcomes of surgical procedure, the results of the functional evaluation of non-operated limbs did not change significantly between 12 months and 24 months after the surgery. So this is really important for us, because we take like a reference group, the non-operated and healthy leg. So when the non-operated leg didn't change in the procedure of the rehabilitation protocol of the life after the surgery, so this is some point for us. Okay, we can take this like a reference group, but now we want check this with control group, the healthy group. Generally, significantly better results in the functional of the operated limbs were obtained at 24 months after the surgery. However, a significant difference was still observed in the functional test at both follow-ups when we compared the operated versus non-operated limb. The isometric outcomes and then isokinetic outcomes, where we look on the concentric and eccentric strength. We take many points of the Biodex. We take the peak peak torque, we take peak to body weight, we take angle of deflection and strength in this angle, but most of the muscle strength parameters were comparable between two evaluations time. This is good. Statistically significant improvement was observed both during the ankle flexion and extension. It means concentric and eccentric in operated limb between the first and the second evaluation. Importantly, there were no statistically significant difference in any of the isokinetic tests performed on the operated limbs between the partial and the total Achilles tear subgroups. So it's why we take this. It's give me the information. We shouldn't we shouldn't wait with reconstruction when we have really problem with Achilles, when we have problem and we have partial tear. Maybe the better way is cut this Achilles, make the reconstruction, and it's give us the good results of the biomechanical assessment. And many more, especially in the isokinetic test. When someone want look on the details, I also can share with this article. But in the present study of the overall satisfactory outcomes are the results of multiple parameters. Equalization of the calf circumference between operated and non-operated limb. A statistically significant improvement in the subjective scores. Better performance in functional test. A statistically significant improvement in the isometric strength of the operated limb measured in the away motion, it's mean in plantar flexion. And a statistically significant improvement in multiple lower limb muscle strength and endurance isokinetic parameters. However, the results of almost all parameters of the operated limb did not reach the values similar to non-operated ones of the first evaluation time point. So it means 12 months after the surgery. But from a medical point of view, it is assumed the healing process is completed 12 months after the surgery. And we many times when we speak with the patient, okay, we talk, okay, 12 months is really good. But importantly, our results indicate that the healing process may take longer than 12 months. Patient after 12 months still have deficit in functional assessment, and they should still, maybe it's not rehabilitation, maybe it's more like a training, sport training, activity training. The most important finding of our work on 30 patients in the minimally invasive Achilles tendon reconstruction enable a satisfactory restoration of strength and functional of the operated area within 24 months, as well as overall satisfaction of patient. Whoa, sorry. Whoa. I don't know what now. Okay, here. Sorry. Okay. For me, the most important thing is this: all of the patients back to the sport activity. To our knowledge, this is the first study which presents a detailed, versatile, clinical, functional, and isokinetic assessment of patient after Achilles tendon reconstruction. We can find the article with some kind of assessment after the reconstruction, but somebody take only isokinetic, somebody take only subjective assessment, somebody take only functional. And for our knowledge, this is the first study when we compare this every assessment. Okay, thank you very much for your attention. If you have some question, of course, you can ask me or you can send me an email. Yeah, thank you.
Thank you, Dr. Bartosz. Thank you for sharing us your excellent presentation. If there are any questions with regards to this presentation,